Ladies and gentlemen, thank you very much for this kind invitation to a pediatric nephrology in critically ill patient webinar. I'm particularly pleased to present the evolution of continuous renal replacement therapy in infants from the clinical needs to the applied technology. In Vicenza, we have been always ahead of time and on the edge of new technologies to develop treatments for acute kidney injury. And in '77, we started our adventure with continuous renal replacement therapies in which arteriovenous pressure gradient was moving blood through a highly permeable filter. We learned very soon that in arteriovenous mode, if you have a constriction or high resistance in the circuit, the reduction in blood flow is inevitable. On the opposite, if you have a blood pump, in this case, you can have a remarkable maintenance of blood flow. So the dynamics of non-pumped circulation was learned quite early, and we developed specific filters for this in order to get maximum blood flow at a given arteriovenous pressure gradient. Very soon, however, we started utilizing blood pumps. Most of the technology was taken from chronic dialysis, and we ended up with the addition of several devices in what we call the Christmas tree, with different possible devices at the bedside of the patient that did not interact one to another, leading to potential error. And this adoptive technology, thanks God, left very soon space for design of new devices that indeed started to be an integrated machine for CRRT, or the first and second generation, until we used the Prisma. That was definitely a step forward. Subsequently, other machines were developed over the years, and also different organ support systems were designed to make available a full rank of technology for adult patients. And here you see the pioneers of hemofiltration in a meeting in Vicenza in the early '80s, and we met several years later here again with Juan Bosch, Lee Anderson, Michael Isaac, and myself. So the evolution of technology led to specific advancements in continuous renal replacement therapy that ended up recently with the most recent last generation machines that we had the pleasure and the honor to test at the first step here in Vicenza. Also, we were able to document the possibility of modifying the extracorporeal circuit by adding sorbents and different other options in a way that we can develop the concept of ECOS, or extracorporeal organ support, which is basically a multi-organ support therapy based on extracorporeal circulation. So this evolution over the years presented significant improvement. But what about the kids? Oh, the kids presented a specific situation in the early '80s. Acute renal failure was mostly treated with peritoneal dialysis. PD was performed with bottles or bags. Gravimetric manual systems were utilized. Ultrafiltration was inaccurate. There was a poorly biocompatible fluid, frequent complications like hyperglycemia, failure of ultrafiltration, hemodialysis not feasible, and high demand of black technology. In other words, there was a situation which is missing a lot of advances in technology. Although I made a specific patent for a device that could measure accurately ultrafiltration in babies and neonates. So there is a transition gap between adult nephrology and pediatric nephrology. A slow transfer of technological advances from adult to children. New technology is often tested in adults only. Lower technological knowledge in the area of pediatric nephrology, and limited engagement of industry. The causes for this are longer times required to validate technology in children, larger experience more rapidly achievable in adults than children. There is a limited number of procedural cases in children, and finally, the small size of the business may keep the industry away from this situation. Having sorted out these facts, there is a need for a transition, and the solution could be cross-fertilization between adult and pediatric nephrologists, support of pediatric studies for adequate product labeling, share the information about unmet clinical needs in pediatric patients, and also push charity and non-profit plans in order to develop technology. So this is a case of a baby, 2.5 kilo, with post-surgical acute renal failure, anuria, and sepsis in 1979. Nephrologist, me in the point, was called to consult the pediatric surgical ICU. Peritoneal dialysis catheter was inserted and PD was started. 35 milliliters per kilogram exchanges with zero dwell time were utilized. Patient developed hyperglycemic fluid overload. Patient deceased after 40 hours of treatment with complications. And this high rate of complication leading to poor outcomes require definitely alternatives that were highly wanted. We started the search to possibly apply extracorporeal therapies in babies and neonates, and we went up to Boston, Massachusetts, where the Amicon company was developing a highly permeable membrane for filters, and we asked it to develop a prototype miniaturized filter. And with this mini filter, in which the resistance was really reduced thanks to a change in the diameter of the fibers, we were able to create a filter that could be applied in arteriovenous pressure mode with a special circuit in the neonate. And this is the very first baby treated in the world with CAVH. Renal function recovered after 96 hours of CAVH, and we published subsequently a series of 4 babies in Kidney International. Babies were treated with arteriovenous circulation, leading to decrease in fluid overload, decrease in time of mechanical ventilation in post-operative follow-up in intensive care units. We try to increase efficiency with larger filters in larger babies, but still these filters were too big. So we developed a specific strategy to modify the filters so that dialysate could be run countercurrent to blood into the circulation. And in fact, severely catabolic patients could be treated with what we described for the first time as arteriovenous hemodiafiltration in this paper published in the International Journal of Artificial Organs. We ended up with the dedicated circuit in Vicenza, and these were utilized in several babies around the world. We also increased the efficiency of treatment with the larger surface area, the so-called mini diafilter plus that you can see in this slide. The interesting aspect was that there was a significant hemodynamic stability due to continuous ultrafiltration and accurate fluid balance because we had a special device based on gravimetric control. Vascular access was critical, and in several babies we utilized the humeral artery and the jugular vein. We also utilize both vessels in the arm or in the femoral position, although we prefer to stay away from the femoral. And in some cases, we utilize even the umbilical vessels with the possibility to utilize the arteriovenous pressure gradient in umbilical artery and vein. Subsequently, double lumen catheters were developed with the possibility to utilize different pumped circulations. as in this case, or in other cases where off-label, where machines for ultrafiltration in adults were utilized off-label in neonates utilizing specific blood pump. This is another machine, NIDUS, that was a syringe-driven pump system via a single lumen catheter, which was having a push-pull system to develop extracorporeal circulation. But as we moved from adoptive technology to dedicated machine in the adult, we tried to apply those machines to neonates. However, showing that this machine, although employing specific pediatric sets, still presented too large priming volume and were prone to develop significant complication. Normally, what you have to look is smallest possible circuit in the extracorporeal circulation. And for a 4-kilo infant with an extracorporeal blood volume, a total of extracellular blood volume of 300 mL, if 1/3 of the patient blood volume is outside the body, then in this case, hypotension may develop quite easily. So in those patients between 2.5 and 4 kilos, we have to look for a maximum 10% of the circulating blood volume and look for a priming volume, which should stay between 20 and maximum 35, 40 milliliters. In order to fix a specific situation, you must have the right tool. You cannot expect to fix the AKI in neonates with a machine for adults, and size really matters. So the neonate required a dedicated technology, and we saw as adult nephrologists that the limited interest of the industry in small volume business has made for a long time AKI in infants as an orphan disease. And therefore, while in other technologies, look, for example, at the history of pacemaker evolution that led to really miniaturized devices implantable in the body, the dialyzers and the machine compared, for example, to the evolution of computers, had a relatively slow development of miniaturization. In particular, dialysis hardware even increased the dimension instead of decreasing, leading to a possible lack of technology in the area of pediatrics. Now, innovation can be incremental with a continuous process toward improvement of an existing technique or technology, or radical conditions where a given device or process significantly differ from what was done before. And while the first is an evolution of technology, the second is a real revolution. And we wanted to drive innovation based on unmet needs, intuition we had, unsolved problems, curiosity, and research and teamwork. And we developed this at our International Renal Research Institute of Vicenza, where the idea of having new technologies is the basis for development of ideas on the basis of interaction between different disciplines, including engineering, pharmacology, biology, economics, etc. So cross-fertilization among different disciplines makes the final solution a multidisciplinary approach. And we stand for the acronym GREEN, which stands for genetics, robotics, informatics, nanosciences, eco-sustainability, putting together experts for all these different experience in our laboratories. And these are our fellows at work to develop different machines. And the idea is to use the Galilean model, which is observe a problem, try to find a solution, measure the results, and come with the final thesis. Galileo was great because he changed current paradigms and imagined. He observed the problem and sought their solution, and he used the new experimental scientific method. He was obsessed by the multidimensional structure of the universe. As a matter of fact, he invented the telescope, but also the microscope, leading to observation of areas of dimensions that before were not observed. He discovered, for example, in his discorsi e dimostrazioni matematiche intorno a due nuove scienze, motion and mechanics, that every object has an optimal dimension. When these are modified, the surface changes by the square, while the volume changes by the cube. Modifying the surface to volume ratio, the structural and functional characteristic of the object changes. So the square cube law is today utilized in several scientific areas, from physics, biology, avionics, nanotechnology, and it is evident that dimension is an important characteristic and feature of an object. I had the pleasure to teach at the university where Galileo Galilei was scaling down machines and mechanical devices, and I had the pleasure to meet Richard Feynman, a Nobel laureate who further scaled devices to a microscopic level, and finally to meet Eric Drexler, a crazy guy who developed the concept around nanotechnology. But who will benefit from miniaturization? First of all, the small baby, the neonate possible. So we tried to develop a project called Carpe Diem, which stands for Cardiorenal Pediatric Dialysis Emergency Machine, making crowdfunding, field building, charity events, project design, and we went through different events, and finally we collected 380,000 euros to start with a new scratch, a new device, a new design from a white paper. And here you see the first designs we made and the filters that we designed, and finally a final product that is our let's say final design of the prototype of the Carpe Diem. We tried physical prototypes at different dimensions, and we tried the solutions for different pumps and application of filters. As you can see here, this is one of the first prototypes we ever used. We wanted to have operational characteristics with blood flow between 0 and 50 mL per minute, ultrafiltration between 0 and 5 mL per minute, with an accuracy of 0.1 milliliter per minute, and the priming volume possibly in the range of 30 or less milliliters. So we went through a design of a professional 3D rendering of the machine, and finally we got in October 2010 the first Carpe Diem machine prototype that was entirely designed by us in the institute, together with two engineers, friend of us. Several new features, including the rotor and the starter of the blood pump, the filter, the scales, the display, and the electronics inside. We went through thorough laboratory testing with machines stressed at different conditions, and blood circulating for hours to try to make sure that we were maximally utilizing the machine, identifying possible gaps. And here is the final product that we came up with practically in 2013, with different characteristics that makes this a complete CRT machine for neonates. Priming volume, less than 40 mL, blood flow rate between 2 and 50, scale accuracy 1 gram. And we have different filters that can present, as you can see here, different priming volumes, which are specific for utilization in babies and neonates. And the clinical case in September 2013, a neonate with severe hemorrhagic shock and multiple transfusion, fluid overload, oliguria, multiple organ failure, and severe subgaleal hematoma came to our observation. The baby was swelling, having acute kidney injury, liver failure, pulmonary distress, and the baby also was treated with extracorporeal circulation using a 4 French bilumen catheter, as in this case you can see. This catheter was allowing the blood flow between 8 and 10 milliliters per minute that was applied for several hours at the bedside of the neonate. In particular, it was applied for 25 days. As you can see here, the blood pump of the system allowed for a very stable venous and arterial pressure compared to what you can achieve when you use a larger blood pump with wide shifts of pressures. The baby was treated with progressive ultrafiltration, leading to a significant reduction of the enormous amount of fluid overload, increasing also progressively the diuresis, and basically net ultrafiltration led to stabilization of the fluid situation in the patient. Hemoglobin and platelets remained stable during treatment. At a certain point, the baby displayed significant hyperbilirubinemia, and we had to treat the baby with automatic exchange transfusion. And also, we utilized the carpe diem for this purpose. We also utilized single-pass albumin dialysis to remove bilirubin, but the most effective treatment was plasma exchange with the prototype filter applied to this machine. You can see here the color of the plasma filtrate and the fresh plasma that was substituting the original filtrate. So we did different type of plasma exchange sessions until liver function recovered and the baby also recovered progressively the acute kidney injury, leading to a concentration of creatinine that was acceptable. And finally, the baby was extubated, and it was one of the big success of our technology. We wrote a book on this, and I want to report the SMS from Cincinnati Children's Hospital. Stu Goldstein told me, "You aren't going anywhere," when I told we had the 4 French bilumen. Finally, when I said it's working at constant flow, he said it's impossible. And then the baby is surviving, and he said it's a miracle. And when the baby recovered, he said this will change the way we'll do medicine in the neonate with AKI. Subsequently, we developed a further evolution, adding the possibility to make a circuit with countercurrent or co-current dialysate flow to blood in order to develop a CVVHD treatment. And these different filters are available for different clearance, as you can see here in this slide. Basically, when you utilize a dialysate flow rate in the range of 5 to 15 milliliters per minute, you can achieve clearances in the range to 6 to 10 milliliters per minute, which represent an enormous amount of clearance in babies and neonates. We developed observation that we could use co-current flow because of saturation being very far from occurring, so the layout of the lines could be much simpler. And in this case, you see that the machine can also be applied in conjunction with the ECMO machine. Now, continuous veno-venous hemodialysis using carpe diem displayed at the first experience a significant improvement in outcomes in the first 13 patients. And when we published this experience in blood purification, this resulted important to have a specific, let's say, information to the scientific community. Now, there was a publication of the Carpe Diem registries with children less than 5 kilos, and specifically, we treated approximately up to 50 patients in the original registry, and the survival rate was significantly greater compared to the previous let's say, patient registries observed in the past. This led the group of United States to consider this improvement in survival as a stimulation for moving forward and observing that the number of patients that presented AKI and received mechanical ventilation and were treated with specific vasoactive medication were improving dramatically compared to what was done in the past. And that was finally approved by FDA. And here is a poster that was presented in 2021 at the CRRT meeting in San Diego, where survival both to continuous kidney replacement therapy discharge and ICU discharge was significantly different. So there was an improvement that led today utilizing dedicated machines for infants in the world, specifically for neonates. The first US patient to receive cardiac support was 1 month old with end-stage kidney disease secondary to Kakut and other very good pediatric institution. Developed fungal peritonitis, 1 MPD, continuous kidney replacement therapy attempted with standard care platform, but transferred to Cincinnati Children's Hospital for a trial with Carpe Diem, and CKRT was successful, and PD catheter removed, the fungal peritonitis treated, PD catheter replaced in the long term after 6 weeks of support with Carpe Diem. The follow-up safely transferred back in UK. He was discharged home on peritoneal dialysis with his first patient last Friday. He will likely be referred to Cincinnati for kidney transplantation in 18 months. And this is what basically Stu Golden collected from the parents. I want to thank Cincinnati Children's Hospital for the continued support you provide to UK pediatric nephrology. This machine saved Brandon's life, and the clinical educational support provided by the Center for Acute Kidney and Nephrology over the past years had allowed us to safely and expertly care for many children in Lexington. But we will never have enough patients, the expertise to care for patients like Brandon, and hope you will continue to be a source of program on our patients. And this is Stefan Kissling from Pediatric Nephrology. Up to today, we have reduced significantly the number of mortality, and we have a large number of patients in which expected mortality rate was reduced by more than half. And Carpe Diem can be considered the heritage of Galileo. So over 40 years of pediatric CRT, there was a progressive evolution towards new filters, new lines, new devices and new machines, with finally developing a specific dedicated technology. In 1984, we had the first series of CABH. In 2014, we published in Lancet the series of Carpe Diem machine patient treated. I think that this 30 years evolution was significant in Vicenza. There are other evolutions available today, like surface treated membranes, in which you can try to utilize, for example, the specific hydrophilic, hydrophobic domains in order to reduce coagulation, and to use this membrane for specific non-thrombogenic application. There are other membranes that have been utilized coated with vitamin E that probably help to reduce the enormous power of oxidant stress present in AKI. And different machines, including carpe diem, require today a specific harmonization of nomenclature. This is what we have tried with the Nomenclature Standardization Initiative Alliance, making different members of the companies signing on the harmonization of nomenclature for different technologies. Finally, in the natural history of AKI, the ADKI group have identified different trajectories that you may evolve into, including end-stage renal disease. We should not forget that patients with acute kidney injury have much higher chances to develop AKI, much higher chances to end up in chronic dialysis. And this is something we have to consider in the future. Concerning recovery and progression to CKD, the definition and characterization of progression is important. The mechanism and understanding how patients progress towards chronic kidney disease and which are the biochemical pathways that may represent target for therapies are important. Risk identification and prediction of progression is important with possible biomarkers, and treatment strategies to prevent limit progression should be put in place. With this, I thank you very much for your attention, and I invite everyone to finally join us in person or even virtually at the 40th anniversary meeting in Vicenza on AKI and CRRT. And with this, I thank you very much for your attention.